Good morning, everybody. On behalf of the Planning Committee, Dr. Susan Fenton, Chris Lehman, and Gabriella Wilson, I would like to welcome all of you to our first Texas Health Informatics Alliance Conference. This event is hosted in partnership with the University of Texas at Arlington, the University of Texas Southwestern Medical Center, and the University of Texas Health Science Center at Houston. Our first conference will mark the beginning of the Alliance and serve as a forum to start the conversation on how the Alliance and our members will contribute to informatics in the area of research, data, policy, education standards, and workforce development. The theme of our conference this year is All In, Informatics Lessons from the Pandemic to Reimagining Healthcare. Throughout the pandemic, it became even clearer that healthcare informatics has developed from the siloed disciplines interest to multi-interdisciplinary focus, embracing all health-related disciplines and collaborations. This is of great importance. Data, knowledge, and informatics will allow us to become more productive and successful in improving healthcare outcomes in Texas. We have a great program scheduled today, and I want to give my special thank you to the Planning Committee represented by UTA, UT Southwestern, and UT Health Houston, who dedicated so much of their time to plan this fantastic event for you today. Before I introduce our opening keynote, I would like to thank each of you for attending our conference and to all of our speakers for bringing their expertise to our event. All of you here today have the vision, the knowledge, and the experience to help us pave our way to a better healthcare system. You are indeed our most significant asset today and tomorrow, and we could not accomplish any of this without your support. Throughout this alliance, I ask you to stay engaged, keep us proactive, and help us shape the future of health informatics. Today's event will be recorded, just in case the 505 of you that have registered would like to review today's sessions. Thank you so much for attending, and I wish you an enjoyable conference. Now, without further ado, I am pleased to present to you our first keynote speaker for the day, Nora Belcher, Executive Director for Texas Ehealth Alliance. She will give a keynote with the title entitled, There's No Place Like Home, Health Informatics Lessons from the Wizard of Oz. Nora is the Executive Director of the Texas Ehealth Alliance, a nonprofit advocacy group that serves as the state's leading advocate for local communities to the national level for the use of information technology to improve the healthcare system for patients. She is one of the state's leading experts in telemedicine policy. Ms. Belcher will speak to you today about the way technology is changing healthcare, the challenges faced by stakeholders and advocates, and the opportunity that health information technology presents to creating a more meaningful healthcare community for the citizens of Texas. Nora, the floor is all yours. Thank you.
Thank you so much, Dr. Ball, for that warm welcome, and thank you to the Planning Committee for including me in what I really do consider to be a landmark event. I think it is extraordinarily timely that the leadership of your various institutions have decided to come together in this inflection point and join hands on collaborative work around informatics. And before we get into the slides, I want to make an observation based on something that Dr. Ball said in terms of the way that this field of study is sort of changing and adjusting. Health IT, not just informatics, but the whole digital health sphere. For a long time, we've been treated like a project. We are those people down the hallway. We're those people that work on that thing over there. We're those nerds down the hall that do those things. And our universe has frequently not felt like it mapped to the bigger health IT universe. And that really started to change with the HITECH Act, with the advent of incentives for electronic medical records and sort of the maturing of this digital landscape that we are all now a part of. So in putting together a keynote for today, I pulled out an old presentation that I had put together in the early days of HITECH, when we still called it meaningful use, before we called it promoting interoperability, and started thinking about, in a post-COVID world, and I know we're literally not post-COVID, although I'm sure everyone on this call would love it if we were actually post-COVID. But the truth of the matter is, COVID has massively shifted the entire healthcare ecosystem in ways that we couldn't even begin to contemplate 5 or 6 years ago. It's accelerated the pace of change. It's strained the system. It's created opportunities. It's created creativity, all these different things. So when you look at all of that, the question really becomes, how do we use informatics, digital health, health IT, e-health, whatever you want to call it, in a way that creates meaningful change in the ecosystem? And in thinking about a keynote, which is what I was asked to do, I thought to myself, you got to have a little bit of fun. So our theme is going to be the Wizard of Oz. You want to challenge, you want to inspire, you want to push the boundaries a little bit of people's thinking and get them maybe thinking about things in different ways. But I'm also, and the folks on this call that know me, particularly Dr. Susan Fenton, who's been one of my mentors for the last decade, knows that I'm basically an incurable optimist. I really do believe in the power of the work that we do to make the world a better place. And so in thinking about all that, I've put together this presentation based on the journey of the characters of the Wizard of Oz for you. And as soon as we can get it queued up, either on my end or through Catherine, we'll be able to get started. But right now, WebEx is not letting me share, so I may need the slides to get run from the university side. Let's see here. Oh, here we go. Now I'm the presenter. Perfect. So this is just further proof that even if you work in technology for a living, technology will mess with you. It's just what it does. We've all experienced it. It took me a long time to stop traveling back in the day with handouts. And remember overhead projectors? I was so distrustful of technology early on, I traveled with overhead projector slides because I just don't trust particularly high health IT setups in ballrooms at big hotels. Their tech almost always fails on me. So now we've got cooperation from the technology. Thank you, technology, for cooperating. And let's start down the yellow brick road. I want to start with a conflict of interest disclosure. I have no real or apparent conflict of interest to report. I'm not going to be talking about any particular products or companies or discoveries or research or anything like that with you today. A little bit more about myself. I've been in public policy a really long time, worked at very senior levels in state government, including at Texas Medicaid, and then for the governor of Texas running the healthcare portfolio. And I'm a former computer programmer. I could make a ball bounce around on a screen on a TRS-80 computer like nobody's business in the 1980s. So I get to work at the intersection of two things I really love, which are technology and public policy. If you're not familiar with the Ehealth Alliance, we are a trade association, which means we represent competitors in the marketplace. We're a 501c6 nonprofit. Again, that conflict of interest statement is not just for today. In general, I can't recommend or endorse specific products. That's not something I'm allowed to do. I do want to mention that we are open to membership for any organization that has an interest in legislation, regulation, and policy here in Texas. If you are a public academic organization, institute of higher education, community college, anything along those lines, we actually have a free membership category for you if you're supported through the state. So if you are not working with us and legislation is of interest, reach out to me. My contact information will be available at the end of the presentation, and we can talk about how you can work with us. So The learning objectives, as Dr. Ball states, we're going to talk a little bit about how technology is changing healthcare, talk about the challenges, and then the opportunities around building a meaningful healthcare community. And we're going to do this through the Wizard of Oz. Now, I do understand that it is possible that some of you have not seen the Wizard of Oz. So that's your homework assignment. If you haven't seen it, there are some spoilers in my presentation. So I guess I'm giving you a spoiler alert that if you've never seen the movie, you will be a little bit spoiled by the end of this presentation. I still encourage you to watch it. It is an absolute masterpiece of filmmaking in a way, quite frankly, that's never been replicated by anything that's ever been done. It was groundbreaking at the time. It continues to be groundbreaking. And I also want to mention, if you're not super familiar with The Wizard of Oz and the work of Frank L. Baum, The Wizard of Oz was actually an allegory intended to encourage the United States to adopt the gold standard. And if you go to Wikipedia, there's a whole explanation of which characters of The Wizard of Oz are actually representing which politicians. So Baum built this beautiful allegory that works as a children's story and works as an analogy for a public policy debate that mattered to him. And inspired by his work, I put this framework together to inspire all of you to think about your work in informatics in maybe some ways that are a little bit different and certainly in ways that are meaningful. So let's get started down our yellow brick road. To level set, this is one of my favorite slides because this slide to me sort of tells the story of the internet and when the users really took off. And so I've moved the blue dot. You'll notice we're not in the 2020s down at the bottom quite yet. Health IT has made some progress the last few years. But the truth of the matter is we've come a long way from the day when America Online sent everybody a CD-ROM in the mail and all of a sudden even your grandmother had email. Well, my grandmother didn't have email. If you've heard me give speeches before, my joke is that she put her iced tea on the AOL CD-ROM because she didn't have a computer to put it in. But all of a sudden we woke up and everybody was online. The COVID-19 pandemic to me is the equivalent of that experience for a lot of our digital health tools. Regular Americans who had never had a telemedicine encounter, never thought about their patient portal being all that important, all of a sudden are having a consumer experience, sort of like the way the consumer internet really started to grow in the early 2000s and is now moving into a customized phase. When the information became accessible and useful to users, that was when we really saw a change in the use of the commercial internet. Now, healthcare is harder than commercial internet. And I can't tell you how many times someone has built an app, a gaming app, a coupon app. I think that's great. I'm all for it. And now they want to reinvent healthcare. And then I tell them to go read HIPAA and get back to me once they read HIPAA and they can explain it to me and spell it properly. And then we'll have a talk about reinventing healthcare. Our universe is just incredibly complex compared to, say, ordering an Uber. And I'm not saying there's not logistics there, but our universe is just way more complicated. So we are moving the way this red arrow is moving. We're just not quite there yet. And on top of that, you don't just have this consumer internet concept, you have transformational technology coming online that's impacting the consumer experience, the regulatory structure, and everything else. So if you think about these waves that are on this slide, we're already into the Internet of Things and smart machines and 3D printing. We're starting to see smart homes and smart buildings and work with virtual reality. Wearables are very common, 3D printing is very common. The next wave of that is things like wireless electricity, going way beyond just a wireless charge pad for your cell phone. Haptic holography, which will mean you'll be in virtual reality with sensors and you'll be able to feel another person in the virtual reality, maybe manipulating your arm in a physical therapy session. We're going to have 4D printing, which is being trialed right now. We'll be able to print maybe arteries and capillaries that are sensitive to temperature because that's what the 4th D in the material stands for. So there's a lot of work being done painting an extraordinary future. For example, right now we can scan and print a 3D heart of a patient. The surgeon can practice the surgery on the 3D heart if they want. 4D printing is going to bring on a whole new array of prosthetics and all sorts of things we can do and a host of ethical issues that will go with it and a host of additional issues around privacy. This is an enormous conversation. How do you even begin to get your brain around it? Well, the way that I like to do it is by storytelling. And so let's move into our story about how do we make a meaningful community for informatics for the things that we all believe in, why you're on this call. And I've got 4 basic principles here drawn from the movie that I'm going to walk you through. First of all is we can't just be the wizard behind the curtain. The second thing is we have to win the loyalty of patients and their families. The third thing is we must stay connected to each other. And then finally, we have to be willing to throw a bucket of water on someone from time to time. That's a spoiler. I apologize. You've had since 1939 to see the movie. So I'm sorry if that is news to you, that that's part of how it ends. So let's break this down. We're going to talk about the characters in the movie. The first character that I always love to start with is the beloved Scarecrow, whose wish is for a brain. And so the quotations you're going to see over the course of my presentation are all pulled from the Internet Movie Database. These are directly from the movie. These are very famous quotes. I love this one. Dorothy Gale, our heroine, is talking to the Scarecrow, and he says, well, I don't have a brain. And she says, well, how can you talk if you haven't gotten a brain? And she says, well, he says, I don't know, but some people without brains do an awful lot of talking, don't they? My goodness, that is an accurate statement on just about any day in almost any setting. But what I mean when I say we need to have a brain in the context of informatics, health IT, how we use it, what that means is we have to use that technology in a meaningful way. We have to be talking about measuring outcomes of substance and not just measuring how much of something we have done. Because just measuring tick marks of a number of procedures that's been done doesn't really tell us anything. And anyone who's spent any time in the informatics space knows that one of the basic goals of our community is to get to that substantive measurement, that smart measurement of the activity that we do. The second part of having a brain to me is that our systems have to be reliable. And in a post-COVID world, I think we've really seen what it looks like when we can't rely on doing business the way we've always done them. Healthcare, for example, is really vulnerable, or perceived as really vulnerable right now on the cybersecurity and ransomware front. Our systems have to be reliable for our patients to trust us. And that means really being smart about the way we build, about the way we deploy, about the way we protect the tools that we build, so we do them in a way that's smart. And then finally, moving into virtual medicine is way beyond just standard telemedicine and telehealth. We are looking at a future that's going to involve virtual reality, artificial intelligence, machine learning, natural language processing, all these tools, but all they are is tools. So doing virtual medicine can't be done just because it looks like fun, or hey, let's stick patients in virtual reality and have them do things. Those virtual things that we do need to be built in a smart and systemic way, not just with an eye towards publishing, although publishing is incredibly important. And for those of you who do that sort of research and publish, bless you, please do more. We have a plethora of data now that we didn't have 2 years ago, and we really need to be smart about looking at the value propositions around virtual medicine, recording, documenting, publishing, presenting that information. But more importantly, doing health IT with the support of all of these things also has to line up with that slide that I was showing you about the consumer internet. We have to make sure the technology tools that we're building are going to line up with the way consumers are expecting to get information. And I started having this discussion before COVID when most people had not had a telemedicine consult. But if you think about the way that people intersect with their cell phones, things are now on demand, personalized, and portable. And there is an entire ecosystem that has sprung up, bringing online healthcare on demand through telemedicine apps, personalized services through those apps and through those companies, all of which live essentially on an individual cell phone. And all of that sounds great, but I would say to you all in the informatics community that if we don't do the first step, which is building all that in a really smart way that lets us track outcomes and gather good data, all of this could accidentally just be on the surface and not really be substantive and meaningful. So as we are building tools that line up with consumer expectations, we also have to make sure that we're building those backends in a way that's really smart. COVID has really changed this in some significant ways. We now know that millions of people have had a telehealth encounter, for example, in a way that a year ago or 2 years ago wasn't considered to be a reality. The question is, what of that do we keep, and how do we keep it in a way that's meaningful and substantive? In other words, to be a meaningful community, we cannot be the wizard behind the curtain. And when I say that, what I mean is there is a tendency in technology land to make the promise first and build the substance later. And I've really been struck lately, I'm sort of obsessed with Elizabeth Holmes and Theranos. For those of you that might not be familiar, I highly recommend John Carreyrou's book, Blood. Theranos was a blood testing startup that was valued in the billions of dollars, and it was based on technology that wasn't real. And eventually that got exposed. Because when you aren't smart in the way that you build things, you get exposed. That exposure comes eventually. So in The Wizard of Oz, obviously, Toto the dog, who might be the smartest one in the entire movie, figures out that this green vision of the wizard is a projection being done by a man behind a curtain. The curtain gets pulled back and the whole scam gets exposed. So when I talk about doing all of these things in a way that have a brain, what I mean is we have to do it in a smart, thoughtful way that takes our patients into consideration as we build the tools. So if the curtain gets pulled back on what it is that we're doing, there's transparency, there's accountability, there's substance, there's a focus on outcomes. The public is in a very stressed out place right now, and there's not a lot of trust in our institutions and in some quarters even in our healthcare community. So when I think about all of the promise of informatics and data to transform the healthcare system, I think it's incredibly important that we do those things in a way that's smart, that has a brain, that is transparent, and that is accountable. And that way, when somebody takes a deeper dive into what we've built, what we're doing, what we're advocating for, we have that accountability. We're not just manipulating things from behind the curtain and telling patients to trust us, and I'm going to talk about that some more in a minute. We really are doing it in a way where nothing is hidden and everything is clear, and that will inspire confidence in the system. So we have to be smart in the way we build the tools. So that's the journey of the Scarecrow. He's the first guy. Now let's talk about our beloved Tin Man. He always just made me so sad in the movie, standing in the rain. He'd been arrested. And then it gets pointed out to the Tin Man at the end, he just wants to have a heart, that a heart is not judged by how much you love, but how much you're loved by others. It's a really important lesson for him because he's looking internally and he ends up sort of surrounded by people who really love him. Well, what does that mean in the context of a meaningful community for health IT and informatics? What I mean is we have to make sure we maintain our connection to the emotional component of the healthcare system. When we use technology in a meaningful way, we're also thinking about community empowerment. And this means taking on things like social determinants of health, as well as things that are purely clinical. It means that the technology in some ways becomes invisible. And when I say that, I don't mean hidden behind a curtain invisible. I mean seamless in its interactions with patients so that they're not struggling to access the tools that we built for them. And finally, we don't sell widgets just to sell them. And that one's really important. A few years ago, I was speaking to a big conference of hospital administrators, and I said, you know, how many of you are doing some telemedicine, telehealth in your facility? And some hands went up. And I said, okay, how many of you feel pressure to do telemedicine and telehealth? Like it's something you're supposed to do. Now, keep in mind, this is pre-pandemic. Every hand in the room went up. And I said, okay, how many of you know what business problem you can use telemedicine to solve? And at the time, most of those hands went down because conceptually that was relatively new. So we cannot just build widgets just to sell them. There's definitely a trend in the broader sort of internet marketplace of taking something that happens in the physical world and turning it into an app. And that's not going to be enough. The things that we do have to be done with purpose. And so that to me is the heart of having a meaningful community and leveraging the work of the informatics community and the digital health community to improve the system. It's got to be done in a way that's purposeful. And part of what that will do is it will inspire confidence in the consumer around the tools. And really, when I talk to consumers about why they don't trust, when I talk to patients about why they don't trust the healthcare system, I get back some feedback that I think is really important to share. First of all, and obviously we're having a big national debate about individual rights, and so I'm not talking about this in a partisan sense. I'm talking about the fact that consumers frequently feel alienated from the healthcare system. They get passed from point to point. Historically, sometimes they've had to take boxes of their records with them from point to point. They are feeling like they have to petition the system, go to the system instead of the system taking care of them, and that they're just a cog in a giant machine of healthcare. We have the opportunity to use data and information to build a more individual experience for that patient that includes making sure if they want certain data to be protected or if they want to have a certain level of confidentiality in their discussions, that that is still respected within the boundaries, of course, of what the law requires us to do and share with healthcare data. Protecting privacy and providing security have never been more important. It's not just the shift of the 21st Century Cures Act to a universe where data sharing is now thought of as more of a default, but it really has to do with making people feel like they are in a good and healthy place when they go to seek care, and that their information is not going to end on the internet. It's not going to end up on the black market. They're not going to be a victim of identity theft. These are real concerns that real patients have. So thinking of a system that has compassion for the people that are a part of it, some of that has to do with sort of saying to the patients that we take care of, we see you and we're building these tools with you as a human being in mind. That's what I mean when I talk about having a heart. And then finally, enabling and empowering healthcare consumers. Obviously, this is another one of those places where COVID has just caused an enormous shift in consumer interaction with the digital healthcare space. That being said, it's still not easy for patients to get what they need. As I've been talking to people who've had, for example, telemedicine encounters over the past 18 months, they find the platforms confusing, takes a long time to get onboarded, maybe they got a bunch of directions and didn't understand them. We're still not really to an easy interaction, even in the digital health space. Now, if you are a technology person, if you're a digital native, or if you're someone who works with technology for a living, you might not really think twice about it. And I don't want to fall into the trap that I think a lot of people fall into, which is making assumptions about older Americans and their use of the internet. Don't stereotype. I will tell you, my father-in-law, who's 85 years old, and I have his permission to say this, went to Texas A&M, loves his patient portal. It's his favorite thing in the whole wide world. It's got his meds. He can talk to his doctor. He thinks it's amazing. And I guarantee you, if he could have a video chat with his doctor through the portal, that would be something he'd be interested in doing. But we also know that we have communities that have been left behind. We have communities without broadband. We have people without computers in their home. We have people that do not have the digital literacy skills that they need to participate. And this disproportionately impacts our communities of color, our low-income communities, and ironically, the people who need the healthcare system the most. So when we talk about enabling and empowering, I'm not just talking about on a day-to-day basis. I'm talking about doing the real work of doing things like mapping broadband access, finding where our Medicaid clients are, and trying to close those gaps so that those consumers can be enabled and empowered to access healthcare in different ways, just like other communities that might have access to more resources. That is what I mean when I talk about really having a heart in the way that we think about the way we use digital tools to interact with consumers. And what that gets us to is winning the loyalty of patients and their families. And I think this is incredibly important. This is a moment in the movie. So this gentleman's name, I found out from the Internet Movie Database, having not known what his name was as a child, is Winky. And Winky is the head guard to the Wicked Witch of the West. And when our heroine, Dorothy Gale, throws a bucket of water on the Wicked Witch and melts her, like I said, spoiler alert, the movie came out in 1939, there's a very scary moment because Dorothy and her friends don't know how the Wicked Witch's guards are going to react to the fact that their boss just died right in front of them. And he drops on one knee and he says, "Hail, Dorothy, the Wicked Witch is dead." So Dorothy actually also liberated all the people in the witch's castle who had been forced to serve her. And the loyalty that was forced now became a genuine loyalty to Dorothy and her cause. This is one of the most important things I have to say to you today. Healthcare has been sort of the fixed point in communities for a really, really long time. You go to your local doctor's office, you go to your local hospital. Now, I understand completely. There are still things people go to the hospital for. I don't want somebody to build up that straw man and pull away from the point I'm trying to make here. What I am trying to say is, based on the feedback that we're getting as an ecosystem from consumers, we have to take the skills, the art of the things that we do and use them to build safe places for patients to come to seek care that rewards their loyalty with quality and good outcomes. I firmly believe that the next decade is going to include some very interesting battles over loyalty in communities. When patients really start to understand that they have choices in the digital space for where they get their health care, what we don't want is for them to abandon their local physician who needs that revenue to keep their doors open. We really need to be thinking about how we build a friendly community and how we build and maintain that loyalty of patients and their families to the providers in their community. And using data, using tools is part of the way we're going to do that. We have to get beyond medicine as sort of a cottage industry. And I'm watching this struggle, not just in medicine, but in dentistry and in optometry and in other spaces that are being threatened. I mean, threatened because that's, I think, how a lot of providers feel. Oh, these digital apps, you know, the patient needs to come see me. There needs to be in-person care. Yeah, a lot of the time there does. But I will tell you that when I talk, for example, to moms of school-age children, if you're giving them the choice between having to take 3 hours off of work to see the doctor and either a telemedicine visit at a school-based clinic or a telemedicine visit from the comfort of their couch after they're off work with their children, which one do you think they're going to pick? We did not build a patient-unfriendly system on purpose. And there are certainly many, many practices in Texas that are patient-friendly. But loyalty is going to matter more and more as patients and their families understand that they have choices in the healthcare marketplace for where they get their healthcare services. So in order to do this in a way that has a heart, in order to do this in a way that is, I think, truly, truly meaningful, we have to be thinking about winning the loyalty of patients and their families. And that means more consumer friendliness in the apps that we build. That means really understanding how the patients are going to use them. There's a lot of data science that goes behind that. That means continuing to improve things like patient portals. Mine feels like it gets upgraded every couple of weeks. And as a Generation Xer who's over 50, I use my patient portal a lot. And I'm seeing sort of continuous improvement in that tool. That reassures me that my providers are taking my access to my information, how it's organized and how it's shared very seriously. And that is going to build my loyalty, not just the outcomes that I'm getting, but the ease of scheduling, something as simple as scheduling. Let's think about this for a minute. People who have to call, be on hold, have to wait to get an appointment, sometimes hang up before they get their appointment scheduled. We know that there's a lot of avoidance. Somebody who can't get off work to go to the doctor might even get that appointment made, but then if their shift changes or they look at their bank balance and they realize they can't miss 3 hours of work, they literally don't go get the health care that they need. And what we know from the literature when that happens is that that makes them sicker. And when they finally enter the system, they're sicker, and that's bad for the patient and it's bad for the system. So when I talk about this concept of meaningfulness and I talk about having a heart, I'm really talking about, for all the buzz of technology, and I love technology, we've got to put the patient back at the center. We have to do that in a way that considers the fact that they have choices and that in a post-COVID world, they're more likely to exercise those choices because of the way that the digital ecosystem has evolved. So informatics as a practice community actually has an incredibly important role, even though you may not be on the front line of actually interacting with patients, building these systems in a way that has a heart that inspires loyalty, I think is part of our community's mission. And part of the way that we're going to assist our providers, whether they're frontline physicians or a big trauma center, with making the kinds of improvements that not just improve outcomes, but bring those patients back to those places when patients know that they have a choice. So loyalty is incredibly important. I am no longer frightened of Mr. Winky. I think Mr. Winky's pretty awesome. That's a moment in the movie that I really, really love. And the lesson there is when you do the right thing, which is what Dorothy did, that does inspire loyalty. So that's lesson number 2. We have to win the loyalty of patients and their families. So let's talk about Dorothy and Toto the dog, who, like I said earlier, might be one of the real heroes of the entire film. One of the most famous lines in the movie, of course, is Dorothy talking about wanting to go home. She wants to go home, and all her friends are in the room, and she loves everybody. And this is one of the most quoted lines of all time, I think, along with May the Force Be With You from Star Wars. Oh, Auntie M, there's no place like home. Well, what does that mean in terms of having a meaningful community? There's a couple of things. So first of all, we have to acknowledge and adjust to the way these new delivery systems are changing. So we've talked a lot for the last 20 years about patient-centered medical homes. But the truth of the matter was we haven't really been doing that in a meaningful sort of way. Patients are still balkanized. They go here for this, they go here for this, they go here for this. Informatics is the place, is the tool that even if the patient wants to see different providers for different things, will help build and is building that superstructure to make sure that there is some centricity around the patient from the perspective of their data and their care delivery. So the informatics community has an incredibly important role to play in terms of things like patient-centered medical homes. Accountable care organizations, to me, still offer one of the great hopes for system change. So for those of you that may be involved in an ACO, be brave, don't quit. The idea of shared risk is still really terrifying to lots of providers. And the more that we can document and show that that can be done in a way that delivers good outcomes and also works for providers, I think the farther down that road we're going to be. I put home telemonitoring on here pre-pandemic for a reason. Because I have a theory. Here's my theory. As a Generation Xer, I do not believe that the baby boomers, for those of you that are boomers on the call, I'm counting on you to completely disrupt the long-term care system. I refuse to believe that the boomers who have defied every expectation ever put on their generation from the day they showed up are going to find the current long-term care system acceptable. So the advent of technology that will let people age at home and let people get healthcare at home started a decade ago, maybe started a little clumsy, but really I think the next 10 years are going to be the golden era of providing services in the home and monitoring people at home, not just post-hospital discharge, but in a more global sense. So the home started as the place we did healthcare, right? Doctors would go to the home. And then we started going to the doctor's office. And now the care is going to come back into the home, not just with monitoring, but in a bigger picture sense of trying to keep people healthy. And I want to make sure I delineate here, we have all been at home, right? Because of COVID. That's not what I mean by home. Yes, these tools are important in the short term, and I don't want to downplay that, but I want you to pull up and think about that bigger picture of aging at home and healthcare at home and what that might look like. It is an unbelievably ripe place for innovation, and I'm seeing it every day. So the patient needs to be the center of the treatment home. We need to continue to develop delivery systems that let us have that flexibility like ACOs, and then we need to be using the home as a site of service in new and creative ways, and that includes things like telemonitoring. That's all pretty straightforward stuff that everyone on this call is probably familiar with, but I want to push it a little bit farther because that's just my nature. I also think health IT and informatics, and actually what you've put together today, kudos again to the leadership of the Texas Health Informatics Alliance, is using health IT tools to strengthen existing relationships and create new ones. First of all, let's talk about between providers. I continue to hear that there are struggles with data sharing between providers. We're doing better. I think the advent of tools like FHIR, the passage of 21st Century Cures, the development of the information blocking rules that just got published earlier this year. Everyone on this call, if you're not familiar with those concepts I just laid out, reach out to me. I'm happy to get you up to speed. But basically, providers are now expected to share information in a way that they really weren't before. Medicaid is a great example of this. The Centers for Medicare and Medicaid Services have told the states, including Texas, that it is now their expectation that we build systems where multiple providers treating the same Medicaid client are actively sharing data if they're working on the same condition. That sounds really great. And let me tell you, it's really hard, and an enormous amount of work is going into figuring out how to do that and to do that in the best way possible. I think sometimes when I talk to people who don't work in the business, they're shocked that it doesn't happen every day. And it does happen. And some providers are great at it, and some providers need some help. And we've got to have systems that enable this in a way that don't create additional huge workload shifts, for example, or workflow changes for our providers. It's got to get integrated. But we also have to strengthen those relationships between our providers. We also are, and I wrote this slide before this event a few years ago. I love seeing closer collaborations between our academic institutions, because our academic institutions are these extraordinary places full of information, and yet people don't seem to know about all the greatness that programs are doing. I love to see collaborators coming together between these institutions. I think the work you're doing today, the organization you put together, helps prove my point. You have built a new home for the discussion of digital health, informatics, how all this stuff fits together. That's an amazing thing. That's the sort of vision that I have when I talk about having a home for the work that we do in a way that's meaningful. So thank you for making me look like I know things, because this is exactly the sort of initiative that I've been trying to encourage when I make statements like, let's strengthen these relationships. And finally, this is a theme I talked about on the last slide. I'm going to talk about it again. I'm going to ask a favor of everybody on this call. Please, 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 in the work that you do, don't forget about long-term care. And the reason that that's extraordinarily important is because of the traditional sort of 80-20 rule. 20% of your population is 80% of your expenditures. It holds true in Medicaid, it holds true in healthcare. The last 60 to 90 days of life and institutional care are the two of the most expensive components of the healthcare system. The HITECH Act did not focus on long-term care. It focused, and rightfully so, on ambulatory care and acute care. Didn't really focus on behavioral health, and I think that was a missed opportunity. Didn't touch long-term care at all. That is an ecosystem that was almost forgotten when all of that was put together. And whether or not that's right or wrong is really not my point. That's what happened. So the digital health revolution, the informatics work, needs to take into consideration where we spend and how that system can be improved. And the truth of the matter is, there is incredible low-hanging fruit in the long-term care universe around serving people in their home, around connecting those providers in meaningful ways, around building better bridges between those providers and the rest of the provider community. A great example of that is something as simple as an admission discharge transfer notification. So this is something that a number of our communities are doing. Houston, San Antonio. It's a short little standardized message that says, hey, Dr. Smith, your patient, Jane, was admitted to the hospital today. When normally that doctor might have been told that, might not have been told that, might have found out in the lounge at the hospital, might have gotten a call from the admitting doc, maybe didn't. We are doing really great work in trying to improve communication around how patients move around in the system. But we have to make sure that home care, skilled nursing facilities, nursing homes, rehab centers, all of those parts of the ecosystem also get plugged in. And when I talk to those provider groups, they're very frustrated. They didn't get incentive money. They didn't get this. They didn't get that. You know, I'm sorry. If I could go back in time and rewrite the HITECH Act, boy, would I do it differently. But it's not fair to second guess and Monday quarterback those decisions. They were made. The question is, if we're really going to talk about having a home, we have to take on those harder issues. And these are tricky, they're complicated, and they're difficult. But this is also when families are going to be at their worst and their most stressed. So when you think about having a home and having a heart and having a brain and doing all of these things in smart ways, I'm not asking you to abandon your current research portfolio and pivot to long-term care, although anyone I've inspired to do that, I'll be all for it. What I am saying to you is that there is a very large, very expensive part of our ecosystem that doesn't get nearly the attention it deserves for its impact on patients, its impact on families, and its impact on cost. And any pivot we can make or any inclusion we can do to that ecosystem, to all the things we already built, is only going to benefit the cause, which is, again, to have a meaningful community that serves patients and is good for providers as well. So that's Dorothy's journey. There's no place like home. We are moving into the golden era of healthcare services in the home in a way that I think a decade ago would have been unthinkable. So we all have to be part of that shift. So what does that mean? We must stay connected to each other. We must stay connected to each other as subject matter experts. We must stay connected to each other as academic institutions. We must keep the connections between the different parts of the ecosystem healthy and robust. And Informatics has an incredibly important role to play in those conversations. We build the standards, we build the tools, we share the information, we develop the best practices, we do the education. The Informatics community is the connective tissue of the healthcare ecosystem. So I love this picture of the 4 characters. They're all together, they're all connected. And to your right on the screen is the Cowardly Lion. So here's where we're gonna kind of wrap this out. If I only had the nerve, or as the actor says, the noive. I love him at a level I can't even really begin to explain. I put his whole speech on the screen, and I'm not going to read it to you, but I will say that any film that includes the line, "What makes the muskrat guard his musk," needs a little recognition for the greatness of this speech. The Cowardly Lion is a coward. He's afraid. He's trying to summon his courage. He wants to be a good friend. He wants to be a participant. He gives this speech, and at the end, he does find his nerve. But what do I mean when I talk about a meaningful community and us having the nerve? Well, for one thing, we were already facing the perfect storm before COVID. Massive demographic shifts among our patients and providers. So let's start there. We have the aging baby boomers. Again, love you, please fix long-term care for me, so I can eat cereal at home in peace when I'm older, like a good Generation X kid, and watch some Saturday morning cartoons. Counting on you, boomers. We have massive demographic growth in our youth cohort. We have demographic shifts in terms of the makeup of America that's changing. We have an aging provider workforce, physician, nurse, across the board, without enough folks in the pipeline to replace them. We're also in the middle, particularly post-high tech, I would say, of the biggest shifts in policy and regulation in the history of being a regulated industry. And for a long time, we had a running joke among my colleagues that the Office of the National Coordinator for Health IT was actually, we called them the Office of No Christmas, because they would drop a 2,000-page proposed rule in December, and we would all spend our Christmas vacation combing through the proposed rule, trying to figure out what they were proposing to do. Thousands and thousands of pages of regulation. How is anybody ever going to keep up with what is expected? And it keeps changing. COVID drove that to a whole new level. So March of last year, I was helping my team track the governor's announcements around COVID flexibilities, and I was literally sending an email out every day for maybe 2 months, because in response to the pandemic, which required flexibility, things kept shifting, and they continue to shift. And then on top of that, as if this isn't enough, we were already in a position where there was competition for resources. Not enough funding for graduate medical education, not enough people in the pipeline, aging faculty at our nursing schools, aging providers, particularly in our rural communities, closures of hospitals. I mean, just all of these extraordinary shifts. And so if you think about being the captain of a ship, the head of an organization, be it a hospital, an academic health science center, whatever, in the middle of all these shifts, this is a lot. And then on top of it, we got COVID as a country. So what does that mean to have the nerve? I learned something really interesting this year. It's actually not true, as I understand it, that the Chinese characters for chaos and opportunity are the same. Somebody said that and it sort of stuck. And apparently that's not true, is what I understand. However, the point I think is a real one, which is anytime there's this much change, it also creates opportunity. A lot of challenging the status quo is a thing we've already had to do, but I will tell you that I'm still seeing, well, this is the way we've always done it, being used as an excuse to not make changes on a daily basis. Some of that is in government where it's hard to make changes. Some of that is in practice where it's hard to make changes. I'm not pretending it's not hard, but we as change agents have an obligation to continue to say, well, let's think about the way we've always done it. Is this really what we want to continue to do? And be innovative in the way that we present those changes. I think COVID in some ways has made it easier, but I also think it's made it harder because I don't know about y'all, but I'm tired. And I'm married to someone that works in direct patient care, and he's exhausted, and everyone around him is exhausted. And when you're exhausted is not always the right time and place to make big decisions, but that doesn't mean that we abandon the opportunity to be people who challenge and push within our institutions and within our communities. I think the second thing about having the nerve is being a champion for patients. And I've talked about that a lot today because it is, to me, that is the center of this entire universe is the patient. And when we are building a new system, changing our approach, rethinking the way that we do things, the patient needs to be at the center of that conversation. Now, I am not advocating for neglecting the needs of providers or not acknowledging financial constraints, but every discussion needs to come back to this basic question. Are we using, fill in the blank, informatics, telemedicine, whichever business tool or concept you want to plug in, to the best possible benefit for the patients that we serve? And when I have that conversation with healthcare leaders, that's a framework that they go, oh, well, we could make this better. We could make this change. We could move this along. But somebody has to ask the question. And sometimes having the nerve just means asking the question. Now, I am not asking you to get up in the face of your boss who's worked at your organization for 30 years and has no interest in change. This is not worth sacrificing yourself for. So let me be clear. I'm not asking you to push that hard. But I am submitting to you that sometimes all it takes is the nerve to ask the question to cause the cascade that creates the change. So don't be afraid to have the nerve and ask the question. And then I think COVID is the world's largest pilot project. That's what I've been referring to it as. Digital health has always had what I call a chicken and the egg problem. And anybody who has ever published about innovation, and I know a lot of you have because I've read your work, we all face this problem, right? Well, show me that this concept works. Well, I have to try it with a relevant population. So, hey, regulator, or hey, Medicaid program, can I try this new concept? No, you can't. Well, why not? Because you don't have proof that it works. Well, we did it over here in the Veterans Administration. Well, that's not Medicaid. Well, I can't give you data that shows it works for Medicaid unless you'll let me do it with Medicaid. And so we're a chicken and an egg and we run in a circle and that loop never gets broken. And I can't tell you how many folks I've talked to over the last 20 years who've expressed that frustration. COVID broke a lot of that wide open. We have omelets now. We don't have chickens, we don't have eggs, we have omelets. But we have to be documenting, leveraging, publishing those lessons in order to create the permanent change. And again, this is where our academic institutions, the informatics community have an extraordinarily important role because you are those people. You are the folks that know how to capture the information, put it through rigorous process, make sure it's tested properly, making sure that the frameworks that are being built for the analysis will hold up to scrutiny. Taking those lessons and making them permanent in the system requires the sort of work that the informatics community does. There's no other way to do it. So now that we are, year and a half into the giant pilot project, we need to make sure that we're capturing what we've learned. I have some great examples of work along those lines that folks have already done. People need to reach out to me to get examples of what that might look like. I've got a couple good ones. And I suspect that there are people listening to me talk right now who are already moving down this road because they've already figured this out, and they're going to be having the nerve, doing the work, getting it published, even if you're publishing about things that didn't work. Sometimes having the nerve means having the nerve to fail, and trying something and then taking the lessons from the thing that didn't work can just as be as valuable as taking lessons from the thing that did work. In other words, we must not be afraid to throw a bucket of water on somebody from time to time. Sometimes that's a reality check. Sometimes it's asking a question that causes a change. Don't be afraid. Dorothy and her friends were afraid of the witch, and it turned out that she was pretty darn easy to get rid of. They might not have done it completely on purpose, but they certainly were able to neutralize her in a way that let them all move forward with their respective journeys. So don't be afraid to throw a bucket of water on people. Be strategic in how you do it, but don't be afraid to do it. So I want to recap. We've got our 4 lessons. Transparency, we can't be the wizard behind the curtain. We have to stay connected to our communities. We have to remember to use the home. We have to do things with nerve. And finally, a shout out to my friend, the flying monkey. I'm also a huge fan of the flying monkeys. We are surrounded by flying monkeys in our day-to-day work. I also sometimes call them Eeyores, the people who say it's not possible, the people who say that you can't, the people who say that you shouldn't. And you know what? They're just monkeys. Ignore them. You know what the right thing is to do. We as a community know what the right things are to do. And quite frankly, the patients in the ecosystem are counting on us to deliver these changes that will make the healthcare system a better place for patients and providers. So Dr. Ball, thank you so much again for having me. It's been a delight to be part of this event. I'm extraordinarily proud of all of you and the work that your group is going to be doing. And I stand ready to be of assistance. Bucket of water, ready to go. You let me know what else that you need. And again, thank you so much for having me today.
Well, Nora, we cannot thank you enough for having given us such a tremendous start with the Wizard of Oz analogies, the loyalty, the importance of the heart, the long-term care aspects, so many ideas that are so close to all of us on the stream and on the call today. We really only have time for one more question from the chat room, and I'm going to ask Catherine if she would give that to us, since you've given us the inroads to change sick care to healthcare as we move forward with your extraordinarily beautiful presentation. Thank you again. And Catherine, would you check the
we do have a question from Dr.
Nenton.
Yes, we do have a question from Dr. Nenton. It reads, first of all, I agree with everything you presented. As we develop this meaningful community for our patients, how do we manage non-reimbursable administrative burden for the end user, i.e. doctors, APPs? Who is monitoring the physician wellness pajama time? ?
Oh my goodness. Thank you so much for that question. First of all, can I just say part of the reason that I love that slide about the internet is because some of our tools are still terrible. And so the informatics community actually holds the key to improving the tools in the workflow to reduce that burden. That's number one. I think number two, and I can talk about this for hours and I'd be happy to talk to you about it. We have to get to real value-based care. And I don't mean you get a bonus for doing this, and I don't mean a bonus for doing that. I mean real financial risk-based care. I have strong opinions about this and a long background in it. We have to move away from the individual action and input, mapping up and down to reimbursement. And we have to move to a universe that pays that provider based on having done the right thing in terms of the outcome. Can't do it without data, can't do it without informatics. We're not quite mature enough yet, But I really worry about the burnout that this hybrid of fee-for-service that we currently live in, where so many things are not reimbursable, is adding to the burden. So I think there's two answers. Number one is improvement on the tools, and then number two is really moving into a different way of thinking about how we pay for things. And telemedicine is a great example. The pushback I got on telemedicine is, oh my gosh, you're increasing access. Like, on what planet is increasing access a bad thing? Well, apparently, if you're a bean counter, it's a bad thing. If you move to value-based purchasing, then the telemedicine encounter just becomes a part of the package, and the outcome is the basis for the reimbursement. That's hard. It's daunting. I get it, but I don't think where we are currently is sustainable. So that's my thoughts on that. And I believe Catherine and the team are going to share my contact information. Please feel free to reach out to me. The people whose questions we didn't get to can reach out to me. I'm happy to continue the dialogue, but I also want to keep the event on track.
Thank you, Nora, for really an incredible start for today. And I'd like to